and welcome to our third webinar in our three-part series called Getting Started with Clinical Photography. I hope you all found it here easily enough. Tonight we've got a lot to go through because this is the meat and potatoes of clinical photography. This is what everybody seems to be waiting for all the time, which is how to use a camera properly. So we're going to talk a little bit about that today. Um, so let me move forward a little bit here. Those of you who've already been to one of my webinars in this series have seen the first one, which is 8 tips for buying the right camera system for clinical photography. That one dealt primarily with not only how to buy a camera, but sort of the steps involved with getting started with it and what you should be thinking about. The second one we went to was 5 ways to use your dental camera for uh, maximum efficiency. And in that webinar, we covered in great detail some of the procedural or systems and policies things that you really do need to think about that I made mistakes in early on in my career when I tried to implement a digital camera system. So those two dealt more with the procedural and how to purchase. They're both available still on my blog, which I'll give you the details of later on. If you go to my blog, you can find that, or my website, which is kriegercontinuum.com. Both of the previous webinars in this three-part series can be found there. So let's go through some things tonight because we've got a lot to talk about. Tonight, the topic is 5 tips to capture amazing dental images. So before we get started, those of you who've been to my other webinars know that I like to throw out some polls every now and then. So I'm going to throw out a poll for you, or actually 3 of them, just to find out a little bit more about who I'm talking to so I can help make this as good as I can. So if you don't mind filling this out, I'd really appreciate it. Your choices tonight are that you're a dentist, a clinical team member, an administrative team member, a laboratory technician, or other. And I see you're starting to vote. I appreciate it because it helps me help you. I'll give you maybe another 5 or 10 seconds to finish this. I see about 50% of you have voted. There you go, picking up some speed here. Give you about 5 more seconds. For those of you who haven't voted yet, it really does help me a great deal. And it seems to me that we have about, 45% are dentists, 30% are clinical team members, about 15% of you are front desk or administrative, and about 15% of you are other. If you're not a laboratory technician, I'm curious to know what other is, but you can always send me an email and we can talk about it. So second poll tonight is I'd like to know a little bit about your history with cameras, just to know where you are with dental cameras. Do you own one? If you don't, that's great. You do own one, but you're not really sure how to use it. You use it, but you could get better, or you feel comfortable, but you need some help. And the last one is you are the master. You walk into a room and your images are better than everybody else, and you're just here for fun tonight. So most of you have voted. And it seems that everybody here owns a camera, which is good. If you don't, that's all right. If you're embarrassed to admit that you don't be. It seems that, about 90% of you find yourselves, or 95% of you find yourselves using it, but you just need some more help, or you're comfortable, but you need just a little bit of assistance. And the last poll, and this is real quick, is just to find out why you're here tonight. Is it because you just want to get some help with the camera settings? You need better composition, you need more consistent lighting, or you need to learn it all? If you only need 1 or 2 of them, you can click on the 1 or 2 that you want. This should be a multiple choice that you can choose a couple of them, hopefully. So most of you have voted. And it seems, interestingly enough, though, this is the part I always enjoy the most because the numbers, if this were a scientific study, wouldn't necessarily jive because about 91% of the respondents, and thank you all for voting, have said that you need either to learn it all. Well, actually, 60% of you said you need to learn it all, and 95% of you are either comfortable using a camera and just need a little bit of help, or need a little bit more than that. So that's good. I know where you all are. Let's get you guys moving so we can talk a little bit about how to get better images. For those of you who've been to the other webinars, you know a little bit about me. I practiced for almost 20 years as a GP in high volume and low volume boutique practices, and decided to cash it all in and go back to school as an orthodontic resident now at Nova Southeastern University. So that's where I am now in South Florida, where there's a thunderstorm going on right now. And if I lose power, I apologize to all of you. Um, just remember this. I took a 6-day-a-week insurance-driven practice to 3.5 days a week with the same revenue in less than 4 years, and clinical photography was the cornerstone. So I'd really like to see you using this. It's part of the reason why I'm out here tonight and why you're here. So this is the obvious question of the night. If I told you that there's a piece of equipment available today that would not only help you survive, but thrive, it would make your practice everything you always wanted it to be. It's affordable, easy to use, proven to work, and implementable tomorrow. And I can't really think of anything else in dentistry at all that allows us an affordable, easy to use, proven to work technology that you can implement immediately. So, I don't think it's going to surprise anybody here that everybody here has already used it. Yes, it's a camera. Now, this may seem a little daunting to some of you who are not used to working with these types of cameras, but don't be. I'm going to try to make that a little easier for you tonight. Because the goal is to get images that look like this, or lab images that look like this. And you might be looking at this image and saying, geez, I don't need images that look like that. I mean, sure, it's pretty and all, but what does it do for me? Well, I hope you're cleaning your articulators before you show them to patients at case presentations. And I think if you're doing that, I think you should have also pretty clean looking images when you present them to patients. And as those of you who sat through my first 2 webinars know, the key to digital co-diagnosis, which is different than digital case presentation, the key to digital co-diagnosis is exceptionally clear images that you can present to patients so they can help diagnose what's going on. And an image like the one that you see in front of you right now is certainly very, very helpful if you're ever going to teach or in a study club, or you just want to show people how to do things. So let's get started with the basic set of images, because tonight we're not going to get into the gestalt, if you will, or the theory or the philosophy of photography. We covered that in detail in the first 2 webinars. Tonight we're talking just about photography. So let's talk about the basic set of images, which in my office as a restorative dentist had 11 basic images. Now, if you're an orthodontist, like I'm going through training now, I recognize that things are a bit different. If you're in perio, there are images that are different. I practiced with a periodontist for 12 years in practice. So I'm going to show you that there's a number of different images we want to look at. And I'm going to go back here for a second. You've got the full face smile, and I want the ears out of the way. And I could have done that better in this picture, but I just pulled a bunch out. I want you to recognize it's important to grade your images, and you'll hear me grade my own. I think intellectual honesty is important. If you don't see something you like, be honest with yourself. Don't say, it doesn't matter. Yeah, it does matter, because sometimes the ears can be an important landmark. But we want a full face smile, and then we want to have a full face repose. I know people look stupid in this image, but this shows me my incisal edge at repose, which as a restorative dentist was my diagnostic starting point. Here's profile. Notice there's no shadow anywhere. Here's my full face, my close-up smile from commissure to commissure with nothing else in the way. So all I'm looking at is teeth and lips. Here's my repose, which is important to talk about repose in this case because we want the repose to be taken after the smile. Because here's your smile close-up, here's your repose close-up. If I start with this shot first and then say smile, and I take that shot, I'll have them smiling off the sides of the picture. And in that case, I'd have to back out, zoom out of the picture to get a better shot. The problem is, I want to see lip mobility, and these are taken at the same magnification. So it's important that you take this shot first, fill the screen, and then don't do anything. Just have them say the word Emma, like the girl's name, Emma. Or they can lick their teeth and just relax. But if you've ever read any of the articles on incisal edge at repose, at least in my office, this was a starting point for the restorative algorithm. So again, start with a full face smile, then go to the up close smile and the up close repose. I'm just going to go back again one more time just to show you. We work from the outside in. So we start with a full face smile, full face repose, profile. Notice again, no shadows except a little bit underneath the chin. I do that from making my mirror, my flash rotate. Again, up close smile, up close repose. Now we start getting into the images that give a bunch of you a little more trouble, and we'll talk about them later. But this is the retracted closed. And by the way, one image that I don't have here is a retracted open where we show the incisal edges open in this shot. You take this one, then you have them open a little bit, take that one. It's a great shot. Now remember, I promised you 15 to 20 minutes tonight. I could easily make this an hour and a half webinar. So if I seem like I'm going a little fast, I've got no ulterior motive. I just have a lot to cover, and there's no way I could do this with you all night. But you're always welcome to email me, and if you stay around till the end, I'll give you my email address. I'm always happy to respond. And of course, give me feedback. I love feedback. So lateral arch shot, for those of you who clicked master, I hope all of your lateral arch shots look like this because this is what I expect from a master. I'm not saying that to be facetious. Contralateral central to second molar, equal amounts of soft tissue above and below, occlusal plane right down the middle. You're not looking up or down at the arch, and you've got a perfect angles classification. This is what you should see from every one of your lateral arch images. And for those who know me, and some of you in this webinar know me, you know that these are my shots every single time. You can see on the top, there's some scratches on my mirror here and there. So I didn't pull you my finest images. I just pulled representative ones. So I take my left and my right laterals, proper angles classification, occlusal plane down the middle. This is my mandibular shot. Yes, my mandibular shots all look like this unless they're really truly tongue-tied. So 75% of my shots look like that, with the tongue out of the way, a dry arch, looking straight down on it, no lip, no cheeks, good lighting. Show this image to a patient, let them look on the lower right second molar, and let you see if there's a crack there. Okay, this is what we need to see from images if we want to get better case presentation. And again, occlusal. I don't know what you can see at home. I think the bottom of my screen is cutting off the distals of the second molars, but I do have them, and that's important. I want to show those. So that's a full set. Now, it's important for you to recognize that the image you see in front of you right now is what I would call an aesthetic dentistry image. It's a beautiful image, the kind of image you show on the wall of your office, maybe put on your website. It's a smile, okay? This does not sell dentistry. It makes us feel good. I heard somebody at a dental meeting once refer to it as dental porn. I sort of laughed out loud, slightly revulsed, but the truth of the matter is it's just pretty to look at. It doesn't do a whole lot more for us. It's an aesthetic dental image. If you want to see case acceptance increase, if you want to grow your practice, you need images that look like this. And this is an interdisciplinary image. Sure, it's not as pretty to the patient, but when you show this image to a patient and they see the abfractive lesions, and they see the staining, and they see the decay, and they see the gray showing through that second molar, and they see the recession, this is what sells dentistry. But more importantly, let's just take the word sale out of there because some people have a problem talking about money. Do you think that this image gives the patient better or worse informed consent than when we feel so good about showing them this image? So again, if you're a master, these are the images you need to be showing. And if you're not, it's okay. But I want intellectual honesty. I want you to sit back and assess your images. On my blog, about, I don't know, 4 to 6 months ago, I had an article that talked about how to grade your images. And it's a nice thing to do. Go back every now and then with a piece of paper and a pen and grade and see what you've got and see if your grades are getting better. And if they're not, try to figure out why they're not. Now, if you're getting images that look like this, they're okay. You can crop them, but you really don't see soft tissue up above. But hey, this is a person who's picking up a camera and shooting an image. So kudos to them for trying and just get better. And if I were grading this, I'd say the angles classification really isn't all that bad. We missed a bit of the second molar, but that's not the end of the world. It's a little bit wet. Well, we could dry it off a little better. And maybe I want to see a little more soft tissue above the upper teeth so that if there's a lesion, we can find it. Plus, for documentation purposes, if there were oral cancer or a lesion or a mucocele or something weird, we could see it here, right? In the soft tissue, you see a little something. I don't know what it is, but it looks like it's something below the lower right first bicuspid, right? Right below the mucogingival junction. Well, we've got documentation. So if they come back a month later, I can shoot another one, right? How many of you have had an image that looks something like this? Nicely composed for the most part, but a fogged up mirror. Maybe the cheek is covering the tooth a little bit. Maybe it's just so dark you really can't see what you're looking at. They say, wow, that's decent composition, and it is. But again, be honest when you grade. It's important. And believe me, anybody who's ever been through one of my courses or a study club course knows I do not grade harsh. I am not a mean teacher. I really try to help everybody. But there's a difference between being harsh and being honest. And we're just trying to be honest. because we can't grow if we're not honest. Here's what we want it to look like. Not bad, right? Second molar is visible, pretty dry, a little bit of moisture. I'd take some points off of my shot for this. There's a bubble there. Soft tissues equal above and below. Occlusal planes down the middle. I can see all my teeth. I wouldn't call this an A, but maybe an A minus, strong B plus. Again, that's how I grade myself. But if you were a first-year dental student doing this, maybe I wouldn't grade an A, a B minus or B plus. Maybe I'd give this an A because I think it's a stellar effort for somebody just getting started. So let's talk about capturing these images. And again, I apologize if I go over a little bit. There's no way I can get through all of this in 15 to 20 minutes without rushing. So we got to talk about camera equipment, which is a camera, flash, and lens, which we talked about in our first webinar. Again, that's on my website, kriegercontinuum.com. It's right on the homepage. You'll see a play button, but if it's not there, you can go to archived webinars, and you'll see it there. We've got dental equipment, which is the mirrors and retractors we'll talk about a little bit. We've got lighting we've got to talk about, and composition. Boy, that's a lot to cover in this period of time, but let's do our best. Well, there's two kinds of cameras you can use, right? You can use a point and shoot or an SLR. Well, the point and shoot on the left sure is easy looking. It's less intimidating. It won't scare your team, and if your team members out there, I know it tends to gravitate towards that side. They're lighter, they are smaller, and they are a little bit less expensive nowadays for the good ones. So what does the SLR offer you? Just more control, and that's it. But the truth of the matter is, if you want images that look like the ones I showed you before, there's a number of features you need to have that you just can't get in most point and shoots. Now, I'm not giving you the opportunity to have a cop out here and go, well, I really need to go to a point and shoot. I'm just going to go that route. Consider the SLR. Remember, now that I'm in school, I'm not really out there on the road as much as I used to be. But I've taught literally hundreds and hundreds of dentists hands-on with me clinical photography. They come from all over the country when I used to live in Seattle, and they'd bring their point and shoots with them. And I'd lend them an SLR just to try. Not one person ever went back to a point and shoot after they borrowed the SLR. Because once you learn how to use it, it's a far better camera. So I'm not going to talk a lot about point and shoots because a lot of the stuff we need to really use in a camera is not available on a point and shoot. And I just wanted to throw out some real quick camera bodies, whether you're a Nikon or a Canon. If you've got something else and you're not sure about it, email me. But these are the two families that really own the market share. Whether it's a Nikon D90 or 7000 or the Canon 50D or 60D or 70D, whatever you've got. I don't care if you have a Rebel. Whatever you're shooting, shoot it. As Lance Armstrong said, and I know it may not be fashionable to invoke the name of Lance Armstrong right about now, but he says it's not about the bike. Well, it's not about the camera. I've taken gorgeous pictures with my iPhone. I wouldn't use them, to present the case, but when somebody says, well, my camera really gives me a hard time and that's why I don't get good images, that's not the reason. It's not knowing how to use mirrors and retractors and not how to handle lighting. And those are the things we'll talk about next. I just wanted to show you with all those camera bodies, you really have a choice on Nikon at least of going with their old 105mm macro lens or their 85mm macro lens. Now, the bottom pictures are the 105 macro. It still is an expensive lens. It's about $950. It's very heavy. I'm on your side out there, team members, and I think we need to go to a lighter lens if we can. They came out with the 85 a few years back, and people were skeptical. So I'm in the photography business. It's my job, in addition to being a dentist, to take in some pictures. And I did. I shot the top row with the same D90 as the bottom row, but I just used the 85mm macro lens. And for those of you who don't know, macro means the ability to get up close, right? If you try to take your zoom lens, and many, many, many people who come to my courses have brought their zoom lens, meaning it's got a dash in it. It goes 18 to 50 or 28 to 200 or 50 to 105. Those are zoom lenses. They're not meant for dentistry. As far as I am aware, there is no macro lens. It's truly a zoom that has different millimeters in them. So you have to have a fixed lens, and it has to have the ability to do macro, means get up close. If you don't have that, you're already fighting an uphill battle. But my point with this picture is consider saving yourself $500 and go with the D90 or the D7000 or any other Nikon with the 85mm Nikon lens. And as you heard me talk about in other webinars, I am a fan of same family lenses with same family bodies. So if you've got a Nikon, get a Nikon lens, not a Sigma or not a Tamron. Get a Nikon lens and a Nikon flash. If you're not buying from a dental manufacturer like, Lester Dine or someone like them who have their own packages. If you're not going through them, buy the same. Because if you have a problem, you don't want to start fighting the camera body versus the lens, and neither company wants to take responsibility. If it's all Nikon or all Canon, you send it back to them. It's their problem, not yours. And remember, I talked about this in the other webinar. If you're going to buy, you got to buy from an authorized dealer. Otherwise, you're buying gray market goods and your warranty is void instantly. But I don't want to spend too much time on that. So we've talked about camera bodies. We've talked about camera lenses. Let's talk about lights real quickly. Uh, the bottom one here, the Nikon R1 macro speed light, is amazing because it's wireless, it's not bulky, there's less controls to have to play with. If you have questions about it, email me and I might put up something on my blog about how to set it up. But it is awesome. I got scared as heck of it at first. It works amazing. But if you do buy one uh, and you need to look in your owner's manual, if you can put this on your Nikon, because the Nikon D90 or the 7000 or the 7100, they all have what we call commander mode. And I know many of you are going to send me an email, does my camera have commander mode? If you're not sure and you can't find it on the web, email me and I'll do the homework. But the problem is, if you don't have a commander mode built into your camera that can control those, you need to buy the R1C1, which is $250 more. Now, it can be adapted to any camera. You can have a Canon with an R1C1 commander module to fire an R1 flash setup on your Canon. But I don't think it's worth it because now you're up to $750 for a flash. And I think there's some very good alternatives for Canon that work pretty well. Like, for instance, at the top of the page is the Macro Twin Light MT24EX. Amazing flash. If you've ever used it, I think you could burn somebody with it. It's so hot. So I'm just comparing apples and apples because that's the flash in Canon, which gives equivalent images to the Nikon R1. That's how good the R1 is for $500. However, if you've got an MT14, which is what most of you might have for Canon, it's a great flash. It works well. It is a double point flash, just like these are. Don't think that it's a ring flash because it's not. If you have the Sigma, also a double point flash. It may look like a ring, but it's actually two separate point flashes. And the reason that's important is facial images. Now, I don't have time to get into that tonight. And this is not a selfless push sorry, it's not a selfish push for my DVD, but my yellow DVD on my website, Exceptional Clinical Photography, gives you 40 or 45 minutes of nothing but tips about how to use your camera for composition, how to rotate the flash, why that's important. And I hope you can appreciate why I can't get into that tonight because it's just too much. But you all probably have double point flashes already. There are very, very, very few ring flashes on the market for macro photography today. So you need to understand the histogram in order to understand how light is being seen by your camera. If you master control of the light, your images will look perfect. Remember that maxillary image from before that was too dark? It's useless. So you've got to have great images and you've got to have great lighting. And the histogram gives you a diagrammatic view of how the pixels of the image are processed by tone. And again, when I give lectures, when I go out on the road or speak to big meetings, this part alone takes me somewhere between 15 and 30 minutes to really go through. I just don't have time tonight. But learn to use the histogram. It is the greatest gift that digital technology brought to us. Clinical photography, before we got to digital shots, when we used film and slides, you didn't have the opportunity to review your image immediately. Well, that's wonderful and all. But the best part about it is the histogram, because it tells us if an image is too light or too dark by counting all of the pixels that make up the image. That's right. If you have an 18 megapixel camera, it is counting 18 million pixels in the blink of an eye, and it's categorizing them by dark and light and gives you a diagrammatic representation of how your image makeup is from a tonal perspective. So if your image is too dark and you're not really sure, it'll tell you exactly. If your image is too bright, it'll tell you also. And you can play with the controls of the camera a little bit to make your images lighter or darker. Again, I don't mean this as a push for my DVD, but I've had so many questions about this that my new DVD, the white one that you see on my website, goes through all of the lighting and how you deal with lighting. Because the lighting is not just about bright and dark, it's also about depth of field. And we'll get into that in a minute. But now that we've talked about a histogram and the fact you need to be using one at first, if you're not a master, true master, you need to be referencing your histogram after every shot. And it takes all of 1 second. But that's counting your pixels. And there's been a lot of misinformation out there about pixels. So let's talk a little bit about pixels. In front of you if we're not on any form of audio delay right now, you should see a picture of a flower. Now, as I zoom in on the flower, it still looks like a flower. And as I zoom in, it starts to get a little fuzzy, or as we call it, pixelized. If I zoom in a little bit further, now you can see lots of little squares of color, right? Those little squares are pixels. People think of them as dots, but they're actually squares, and each one can only be one color. But if you go backwards and look, it makes up a picture. So again, as you come in, the image gets more pixelized. Well, what difference does that make? For most of you who are not up on the big screen giving lectures, and even if you are, it doesn't make that big of a difference, you're going to show your stuff to patients on a screen. Now, the average screen nowadays for a good screen in your practice should be about 1900 pixels wide by 1200 pixels down. If you do the math, that adds up to 2.28 million or megapixels. So if you've got a camera that's 12 years old and it's a Fuji S2 and it has 6 megapixels, and I go to you, well, you really need a camera that's 18 megapixels. And you say, but wait a minute, my screen only shows 2.28 megapixels. Is there any reason why you need to go to a new camera for that reason alone? No. The resolution on your camera is more than satisfactory for anything you're going to do with it. Now, might you get better color from a newer camera? No question. Might you have a bigger screen on the back of your camera? No question. I covered all of this in my first webinar. But if someone's going to try to talk you into buying a new camera just because it has more megapixels, that's a mistake. Because unless you take a really bad image, and if you're using my techniques, I'd like to think you're not going to get really bad images. You don't have to crop them a whole ton. As a matter of fact, I don't want you cropping images because it takes time, and time is money. I want you to go from A to B as fast as you can. So if you're not cropping your images, you're filling the screen. Doesn't matter how many megapixels your camera shoots, you're only going to show 2.28 megapixels. So again, remember this when it comes time to buy a new camera, because it doesn't matter if one camera has 18 megapixels and the other has 21. They're the same thing on your screen. Now, depth of field is important. I want you to look at this keyboard shot. This was taken with a low f-stop or aperture setting. And again, there's just not time to get into this tonight. But I want you to be aware of this stuff. This is the kind of stuff I cover in great detail on my white DVD. That's, again, about 40 minutes long, and it's a great tool to be able to train your team and really as a reference. Now look at this keyboard. You can see the tab key in focus, the Q and the W's not even in focus at all. This is what's known as depth of field. The further down you can see, the more depth of field you have. Now, the lower the f-stop, the less depth of field you have. That's why I had to use a low flash setting or vice versa. I threw out very little light, so I had to turn my f-stop all the way down. If this sounds like a foreign language to you, don't be worried. I don't expect you to get this all right now. I just expect to open your eyes to it. If I turn the f-stop all the way down to let in more light, which will be shown by my histogram, which will let me see what's going on, I'll have a very, very poor depth of field. However, this is an example of an image taken with a high f-stop because I had a very strong flash setting. I threw out a ton of light. It was too bright at a lower f-stop, so I had to turn my f-stop way up, and that gave me great depth of field. I want you to notice the difference in the depths of field of these two. Now imagine that instead of it being tab, that's the central incisors as I look backwards. I can get my centrals and my second molars in focus at the same time. So if you don't think depth of field matters, you're missing the boat. Because think about the distance on the right image from the tab to the E. That's about 4 inches. So if your staff member or yourself is shooting an image and you're slightly out of focus, it doesn't matter. You're going to get it all in focus anyway because it's much more forgiving. So is the SLR camera a little more confusing? At first, yes, but it allows you much more control so you can get a very, very good depth of field, and you can't do this with almost all the point and shoots that are out there. So last but not least, before we get into actual shooting the images, let's talk about setting up the camera. In real short, the ISO setting is just the camera sensor sensitivity to light. You can look in your manual. It'll show you how to set it. The higher the number, the greater the sensitivity. This is what, if you're going to write down and take notes, just remember, set your ISO to 200. We can get into long details about why. I covered in detail on the DVD. It's not important right now. ISO 200. I've tested all the ISOs. This is probably the best for the mix of what you're looking for. Image type, there's so much we can talk about. Generally, it's TIFF, JPEG, or RAW. Stay with JPEG unless you're doing for like the AACD accreditation process and they require a raw image. Always shoot JPEG. Again, I'm not going to get into details here. It's just way too little time for that. But you have a choice of large or fine. With storage being what it is today on our SD media cards or compact flash cards, you can buy, geez, 8 GB, which is probably thousands of images for you. So don't even worry about it. Just shoot large JPEGs and you'll be beautiful. It'll be fine. So let's talk about some other settings. White balance, if you don't know what it is, you shouldn't even be talking about it. It basically allows you to color calibrate your screen on your camera, but you don't need color perfectness. You don't need color correctness as much as you need color consistency for almost all your images. If you're worried about color, we can get into a long esoteric conversation about it because I've spent over a dozen years, no pun intended, focusing on it. And I'm telling you, it's a waste of your time for a lot of reasons. Don't worry about white balance. Don't worry about color temperature. These are things that are going to waste your time. Get good lighting, get good depth of field. You will love your images. Think about Best Buy. When you go to buy a television and you love that TV you've been staring at, it looks awesome until he shows you the one that's 3 times the price next to it. What you realize then is there's a difference. But what you had in front of you was fine because it was consistent. When you compare it to something else, that's a problem. And for those of you who might change camera systems, that could be a problem for you. But like I said, don't worry about that. All of you should be shooting your camera on aperture priority unless you own a Canon Rebel series. Then you need to shoot on manual. Okay, if you're shooting on automatic, you might as well be shooting a point and shoot because your camera is making all the decisions and you don't have any choice over depth of field or lighting or f-stops. So again, with very few exceptions, shoot aperture priority for all your Nikons. For all of your Canon and higher end Canons, you're probably going to shoot aperture priority, AV on the dial. But on your Rebels, you're going to want to shoot manual. Retractors can be plastic or metal. It's a personal preference, but look at the difference between this plastic and how it holds the lips out of the way. And then you go to a metal, and look what, oops, sorry, I got rid of, look what happens to the lips. Yes, there are metals that are shaped more circular, but they're a problem. You can't cut them down. You can't mess with them. I don't think there's a place in today's day and age for metal retractors. I haven't used them in 10 years, and I would never recommend you consider them. Uh, by the way, you notice in this picture there's a cant. Important to capture the cant as it is. And you have to look outside of the camera, look with your eye and see the cant and capture it appropriately. Because in ortho or restorative dentistry or in oral surgery, if you're doing any sort of surgery, the cant is important. And in perio, of course, if you're doing crown lengthening. So keep that in mind. These are my retractors that are available at my website. This is not my push. I'm just showing you. You can cut them down yourself if you want to. This is what I show on my DVD. These are game changers. If you're not using your retractors looking like this, you're missing out big time because the retractors we have currently for all of our images are keeping us from getting great shots. Mirrors, rhodium coated is the standard. If you want to use stainless steel, you can. You're not going to see the same quality. It is a poor man's mirror. I've had this debate with a number of people. They do scratch a little bit easier, and the reflectivity will never be close to rhodium. Chromium is truly a poor man's mirror. Rhodium prices have gone through the ceiling in the last 2 years, more expensive than platinum. But this is what's been used for 50 years. I felt that traditional mirror designs, after watching my hands-on courses, I watched a lot of you out there struggle, particularly with those weird shaped lateral mirrors. I don't know what they're trying to do with that, but they've been around since the day the camera was invented. They're the radius on them is very, very big, and it's very hard to get distal without hurting a patient. What that other end is all about, I have no idea, other than the occasional lingual sextant, but you can shoot that with any mirror for the most part. I found the occlusal mirrors, like the one on the right, had too much concavity, and those were a problem. So I redesigned the mirrors and came up with some designs of my own that I felt worked a little bit better. You'll notice that they look like the traditional occlusal mirrors, but they're longer, so you can really get your hand on it without shooting your thumb or your finger. There's my lateral shot. You'll notice that the ends are more tapered, and they're thicker in the middle, so they retract lips better, and the ends are tapered so you can get them more distal. Again, I cover this in great detail in the DVD about how to use these differently, and they're four-sided, right? So instead of that weird shaped end, which becomes useless for you, if you scratch them, you have the opportunity to flip it over and have three other sides. Now, I wish you could go to Hugh Freedy or some dental supplier, and I'm in talks with Lester Dine about them carrying my mirrors, because honestly, I don't like selling mirrors. I don't enjoy it, but the only place on earth you can buy these is my website, only because there's not a big markup in mirrors, and most people just don't want to sell them. So uh, I want to talk about the toughest images that are out there right now. So let's talk about the retracted closed image. You want the patient seated, not standing. The camera's held horizontally, not sideways, the tall way. You're holding it flat. So it's held like you ordinarily would hold a camera. You have both your flashes on. You put sunglasses on the patient. You want to get second molar to second molar. Fill it just with second molar, second molar. You don't want to see cheeks or tongues. If you're seeing more than that, getting closer. Don't be afraid. The arch should be centered, and you want to shoot it like in nature. You remember the one with the cant before? Capture the cant if it's there. And again, use the regular retractors, my big retractors. Those work best for these. You got to dry before you shoot, and you can dry either with air, or I like to use high-speed suction. Works better. And no lips, no retractors in the image. So you see this? Not a bad shot, but the person just needs to come in closer. It's a little wet, but if they got in closer from second molar to second molar, you'd see things better. Notice the pathology above the central and above the cuspid. Nice to be able to diagnose that. So again, if you're getting a shot that looks like this, not bad. Just get in closer. That's important to keep in mind. Not quite as good, right? You're shooting up at the patient. Notice how the occlusal plane slopes downward. That tells you if you go back one, notice that's flat. It curves like the curve should be. This one's sort of upside down, and off the one side showing more than the other. So let's go to the lateral arch shot. Again, this is one of the tougher ones for most people. This is where masters are made, if you will. Again, patient seated, the camera is held the same way, both flashes are on, sunglasses are on the patient. When I say both flashes are on, I mean both your point flashes, because when you're shooting a full face, you don't have both flashes on. You only keep one on. Again, on the DVD, I cover that in great detail. You want second molar to contralateral central. The occlusal plane, you want aligned right down the middle of the mirror. All the teeth are on the same plane. So you don't have a very small second molar because it's far away and a giant central. You want them all to be representative. Again, dry it before you shoot it. This is where using a high-speed suction makes all the difference. And again, this is where my small retractor, not my occlusal retractor, but my small retractor goes on the contralateral side, and it's moved to the midline. Because if you pull on the contralateral side, you're pulling your mirror as well. So again, don't do that. Use a small retractor on the other side. That way you can really get your mirror out there. And again, no lips and no retractor in the image. Same thing on the other side. Right lateral, patient seated. Everything's identical. There's no difference here. Second molar, contralateral, central. You want a flat occlusal plane right down. If you have two plane occlusal plane, capture it as in nature. And again, no lips or retractors in the image, and dry the teeth before shooting. Same magnification as a left lateral. Important. You want to be able to show a left and right lateral side by side. So don't zoom in on one and zoom out on the other. If they're missing teeth on one side, capture the ridge. Same distance. Again, that's where if you use autofocus, you run into trouble. That's why I like to use manual focus, so I can move forward or back with my camera till it's in focus. Then I know I'm the same distance as the other side. So here's a shot. Not bad. What's the problem? I see fingers. Why fingers? Because they're too far away. Imagine in your mind to put your fingers over the screen and crop it. And if you were to crop this image, you'd actually have a beautiful image. So what's wrong with clap? What's wrong with cropping? Nothing if you want to waste your time. If I can shoot it and don't have to waste time cropping, I don't want to. Did they miss the second molar a little bit? Yeah, but I'm okay with that. It's not diagnostic necessarily. And I'd rather see a straight occlusal plane. I'd rather see a great angles classification than to compromise all that, because you really had to stretch the mirror the wrong direction to cheat a little bit to get a second molar. Right? Here's one that was shooting up at the arch. Here's one we have the same teeth blocking the second molar. My angles classification is not appropriate. Look how we're looking really pretty much straight on at the cuspid. right? We're not really looking straight on at the second molar and the way it interdigitates with the lower second molar. We're looking straight on at the cuspid, bicuspid region. That's your indicator that you really didn't stretch them enough, or you didn't move your retractor on the other side to the midline, or you used too big of a lateral mirror. And believe it or not, I use the big lateral mirror, the large one, for most of my shots. I'll go to a medium one for most adults when I can't fit the large because I love getting the soft tissue. But the little one, which is tiny, you'd think is only good for pedo, which it is, but the little one is actually really good for smaller mouths. So again, I have three sizes because all three sizes are used by me on a regular basis. Last two shots, the maxillary arch. Again, patient is seated, camera's held horizontal, both flashes are on, sunglasses are on the patient. You want to capture all the maxillary teeth. And here's the interesting point. You're going to get the occlusal surfaces 90 degrees to the mirror, meaning the front teeth are not closer to the mirror than the back teeth, like you see in some of your shots out there. I want to be straight down, like I'm laying down on their tongue, staring up at their teeth. This is where you use my split retractors. Because if I'm shooting a maxillary, why do I want to retract my mandibular teeth, my mandibular lips? All they do is keep me from being able to get what I need. And if you've ever had a patient who said, oh, I can't open wide enough, well, it's because you're using the wrong retractor, generally speaking. Go to a split retractor, it'll make all the difference. Again, dry the arch with this high-speed suction. Notice there's no nose. We're not looking up the nostrils. The retractors are there, but they're unobtrusive. If you have metal retractors, it's almost impossible. Here's a good example of where the front teeth are closer to the mirror than the back teeth. And you really can't see the linguals of those upper front teeth. And if you want to show crack lines in teeth and breakdown of old composites, you need to see that lingual. Here's another one off center, fogged. Not a terrible image, but if I was going to grade this, I'd call this a B minus, C plus. Right? The second molar on the patient's upper right is not visible. The linguals really aren't that visible. Be intellectually honest. Don't look at this and say, well, it's good enough for me. No, it's not. If you're spending some of your time listening to me jabber away about photography on a night where you could be hanging out with your spouse, playing with the kids, golfing, whatever you could be doing, and you're sitting here with me, I think you should strive for more than just decent because it means you're committed, and I'd like to see you do better. So to me, this is a B minus, C plus. Strive to get that A. Keep it in your mind. Be honest with yourself because it takes very, very little effort to get better. There's an old saying, good is the enemy of great. So if you're doing something good, why do you want to be great at it? That's a problem. Be great at this. Strive to do amazing images. So here's your last but not least. Here's your lower arch image. Tongue is out of the way. Things are dry. So let's talk about it. Again, the patient's seated. When we shot our occlusal, we were shooting from behind. They were laying flat. We were standing over them, nose over nose. Remember that. It's on my DVD. I covered in great detail. Both your flashes are on. Everything's on. Everything's the same. But remember, on this one, you're standing in front of them, like where we drill from, by the right side of the patient if you're a righty, left side if you're a lefty. If you're a righty, never get on the left side of the chair. There's no reason for that. Stay on the right side always. That's where we operate from. It's like Hitch. You remember the movie? This is your zone. This is where you stay. Stay on the right side of the chair, or only for the occlusal of the maxilla do we get behind the patient. Okay? So use the split retractors again, only on the lower lip. Dry it before you shoot it with a high-speed suction. And then no lips, tongues, or retractors in the image. Important to keep that in mind. So before you disappear, a couple of things. You can visit my website, KriegerContinuum.com. If you use the web code WEB114 when you check out, you get 10% off anything you purchase for the next 48 hours. I want you to take good note of my email address. It's Glenn with 2 N's at KriegerContinuum.com. I love feedback. So if you loved what I did, wonderful. I'd rather hear you say things you didn't like or what you'd like to see in the future. I learn a lot more from criticism than I do compliments, though compliments are always accepted. I want you to go to my blog. I don't get anything if you go there, other than the satisfaction of knowing that I'm hopefully reaching an audience. I've had 48,000 hits since I put it up. It's dentalphotography.blogspot.com. I cover all new technologies that are out there. If there's something you see and you're curious about and you don't know much about it, email me. I'll talk about it on the blog. It's followed in probably about 15 countries right now. So please hit me with emails about anything. I'd like to offer you the opportunity to ask any questions. So if you have questions, you'll see a spot you can type them in. Everybody but Dr. Shaw is allowed to ask a question. I know Dr. Shaw from personal, and he's going to do nothing but cause trouble for all of us. So, what is the website where the previous webinars are available? Dr. Cooper's asking. Uh, and thanks. Well, you're welcome, Dr. Cooper. This is absolutely my pleasure. Uh, you may have put that in there before I got here, but if you go to my website, kriegercontinuum.com, my latest webinars are always going to be on the home page with a little play button. So I think on my home page right now on the left side is the 8 tips for buying a camera. Right to the right of it is, I think, the 5 tips for using your camera system for maximum efficiency. So you can go there, or it's on my blog, but I think it's easier to see at my website. Please, if you have any questions, now's the time to ask them. I know sometimes there's a delay and it can be difficult. If you have a question about your particular camera system, I'm happy to answer it as well. But again, my blog will give you the opportunity to see a lot of the details about a lot of the stuff that's out there. Uh, Sometimes there's a delay, so I'll give you guys an extra 15, 20 seconds to ask any questions. And if you want something to be left anonymous, I'm really, really happy to not mention your name and just right at the beginning of it or the end of it, just type ANON, anon, and I'll know that there's no need to mention your name. And again, thank you, Dr. Cooper. I appreciate your kind words about the webinar. This is why I do this. So again, I'll give you guys and gals another 10 seconds. Dr. Shaw, as expected, is giving me terrible questions that I will not share with all of you. Will I be posting this webinar online as well? Yes, I will definitely. I think it's important, having owned my own practice for a period of time, to have uh, a resource, if you will, for your team to be able to be a part of this. I want to be on your side. I want to help you with your team. That's why I have the DVDs. Again, I don't mean this to be a selfless push for the DVDs, but if you really need help getting to that next level for composition and lighting, I really tried to cut the cost considerably if you buy both at the same time. So these will be posted so your team can go look at them and get some good insight. And again, in my first 2 webinars, I speak very, very clearly, and this goes out to you, Dr. Rotenberg. I speak very, very clearly about that we don't make excuses. And I'm not going to be scared of implementing this stuff because I have team members who are rolling their eyes at me. If my practice is going to be the best it can be, and you don't want to be on board with that, I have no problem asking you very kindly to please find another place to work, because I'm dedicated to excellence, and I hope that everybody in my office is as well. So hopefully that answers your question. I will post this, and if it's not on my homepage, it will be under the little top thing that says archived webinars. And I will put, this is just, and a couple of people have already left, but I'll tell you, this is just my 3-part series on getting started with clinical photography. I hope all of you can appreciate being a full-time resident. It's a little challenging to be able to do this very often. But once I do this for the West Coast times, which will start next month, a little bit later in the evening, I will start another series that'll deal more with technology like Photoshop, PowerPoint, Keynote, editing images, things like that that people often ask me about. So I'm going to keep archiving these so that you all have an opportunity to see more and more of this. Dr. Freckman, it seems, says use a Pentax with a ring light for intraoral and point for full face. I'm not sure if it's okay. The Pentax is an oldie but goodie. If it's with a ring light, um, I'm hoping it's digital. The Pentax with a ring light that I knew about was a film camera. If it's digital, sure, you can use it as long as you have the opportunity to adjust the flash power. And again, I didn't have time to get into that tonight. I cover that in great detail on the white DVD. I call them the white and the yellow because you'll understand why. I do cover that in great detail with the white DVD. So if it is digital, and I see you responded that it is digital, then it's great. But you have to have the ability to alter the flash, because if you can alter the flash, guarantee your camera can adjust the f-stop. Every digital camera does that. But if you can alter the flash and you understand it, the more your flash goes up, the more light you're going to be getting in, the more you have to turn up your f-stop, the greater you get a depth of field. It's one follows the next. It's a system. And so if you can't alter your flash, you may either have too much light when you get up close, or you may have too little light when you want to shoot a full face. So I'm not a fan of a ring flash because it throws light out everywhere and your shadows tend to get obliterated. And you might say, wait a minute, he said in our full face images, we don't want flashes, we don't want shadows. Well, that's true. However, when we get into the mouth, we want shadows. That's what shows us our negative space. That's what shows us our embrasures, our surface texture. So ring flashes tend to obliterate that. If you want to make your ill-colored crown look great, use a ring flash. It works really, really well. For those of you who have just sent me questions or comments and said you're sorry you missed the other webinars, don't fret. As I mentioned, they're on the website. So again, KriegerContinuum.com. If you use the code WEB114 over the next 48 hours, you'll get 10% off anything, and that includes things that are already uh, discounted. So if you buy both DVDs, they're discounted considerably. I have a kit called the Starter Kit, which has both DVDs, a full set of mirrors, and a full set of retractors. Is it expensive? Yes. Is it discounted considerably? A ton. Why? Rhodium, like I said, is more expensive than platinum. And you're not going to find this anywhere else. Unfortunately, I wish I could sell it to you through somebody else. But if you buy the starter kit, you've got everything you need to get started. You can put your team member in a room to watch DVDs and walk away and know that they're going to know what they're doing. So with that, I want to thank you all for the kind comments you've made. If there's anything you want to see me speak about in the future, I'm happy to go through it with you. Just send me an email. My email address is here, glenn@kriegercontinuum.com. Uh, I see already people saying they wish other team members were here to see this. And again, I'm happy to let the discount last until decision makers could view this webinar because it seems like some people here may not be the dentist. Just please, if they tried and it doesn't work or you tried and it doesn't work, email me at my website, glenn@kriegercontinuum.com, and I will make sure to give you that discount. I think you should be rewarded for spending your evening listening to my terrible voice. So with that, I want to say thank you and wish you all the best of luck. And if there's anything you want to see me speak about later, please do me a favor and send me an email because that's the only way I learn how to give you what it is you're looking for. Thanks a lot and have a great evening.